The following podcast is part of a certified educational activity titled Setting New Expectations in Multiple Myeloma, Guidance on BCMA, CAR-T, and Antibody Options to Enhance Patient Care. Access the entire activity and complete the post-test at peerview.com/MKV860. Downloadable slides and practice aids are also available.
I'm Sagar Lonial from Emory, Atlanta, and I'm joined by my colleague, Dr. Krina Patel, the newly married Dr. Krina Patel, by the way. She's got the ring and the hands to prove it. And we're going to spend the next hour or so talking about setting new expectations in myeloma, guidance on BCMA, CAR-T, and antibody options to enhance patient care. So where are we in 2023 when it comes to managing patients with relapsed and refractory myeloma? This is a nice summary curve that really establishes the difference that new therapies have made to outcomes for patients in the last 50 years almost. And what you can see is a subsequent improvement in disease-specific survival based on decades in which this was done. And what we have shown at our group, and Krina was waiting for me to say this, in the RVD 1000 series, is that the median survival is now over 10 years for the average myeloma patient. And I saw a new patient on Tuesday and said, not only is it over 10 years, but this data is 10 years old. So it's likely even better than it was. The challenges are, however, that many of our really good active drugs are getting moved earlier and earlier. So when patients develop drug resistance, the options are a little bit more limited. And this really, I think, unfortunately, is the reality of many of us who see a lot of myeloma patients. We have a lot of people that are doing really well for a long time, but when they stop being sensitive to the big three classes of drugs, CD38, proteasome inhibitors, and IMiDs, we really are in a bit of a quandary. And this really demonstrates some of that limited progression-free and overall survival for patients with triple-class refractory or pentaclass refractory multiple myeloma. And the options in that context really are quite limited. And that's really going to be the focus of what we're going to spend the next 50 minutes talking about. So what agents do we have available in that context? Well, we have and then had belantamab mafodotin, which was the first BCMA-directed antibody-drug conjugate, ide-cel, cilta-cel, teclistamab, and most recently elranatamab. And then around the same time, we also have telketamab. And you're going to see some data on each of these novel approaches for managing patients with triple-class refractory disease. And as we do in myeloma, when it works late, we bring it earlier to see whether we can ultimately get to that cure plateau, which is what I think we all really want to see. We want to get patients not just long, deep, continuous therapy remissions, but ultimately get to curative therapy where we can stop treatment and let patients get back to their normal everyday life. So our goals for today really are to improve your knowledge on the mechanisms of action and clinical evidence supporting BCMA-directed therapy, enhance your ability to develop sort of a personalized treatment approach, and finally equip you with the skills to manage safety, therapy delivery, and patient education considerations in the context of BCMA-directed therapy. And with that, I will turn things over to my colleague, Dr. Patel.
Perfect. Thank you, everybody, for being here. So I'll start the next 15 minutes just talking about breaking the glass ceiling of conventional care with BCMA CAR-T, one of my favorite topics. And we're starting with a case and kind of discussing what we would do differently, because again, myeloma doctors have so many options, which is amazing. We might do completely opposite things for the same patient. So this is David, who is 70 years old, PSF1, had len bortezomib dex induction, had an auto transplant, and then unfortunately progressed after 2.5 years of len maintenance, which is a little bit early. At relapse, we repeated set of genetics, and he does have high risk with 1q amplification. So Sagar, you see this patient come in. Would you consider CAR-T? I would, because I love CAR-T for everyone. I would do it at diagnosis if I could, or other standard of care regimens.
Yeah, I think this is a really good question, and in many ways is addressed by some of the data that you're going to touch on in terms of the use of CARs in earlier lines of therapy. I think as of September in 2023, I think that a DARA-based approach would likely be the standard. But I think the other consideration is that this, with a short duration of remission, only 2.5 years after initial diagnosis, this patient meets the definition of functional high risk. And so we need to think about how we would approach that.
Agreed. If they had 1Q at diagnosis, would you have done maintenance or anything else differently?
Isolated 1Q, I'm not so sure.
Got
but
it.
certainly with 1Q plus something else, yes.
Like ultra high risk, yeah, I agree. And I do see these patients quite often where they relapse so early and we just see the 1Q. And then DPD or DVD, what would you use, let's say, until you can get even if you could get a CAR T, or if you decided a standard of care, what are your sort of CD38 regimens?
Yeah, so in a patient with a short duration of remission, less than 3 years is our cutoff for DARA CARDEX versus DPD.
Agreed.
If they've had more than 3 years of PFS, then we would use DPD in that case.
Yeah, no, perfect. And I think the only difference was during COVID where patients couldn't come in, or if they live far, then DPD is sort of the main thing.
So what is your just sort of experience with CAR in a high-risk patient early?
So much better than my experience in CAR as standard of care fifth line, right? So I think for my patients that were fortunate enough to get on the trials, when you have high risk at diagnosis or in second line, to get to fifth line with your attrition curves, right? They usually don't make it, or by the time they make it, I can't keep their disease controlled to wait for 8 weeks, 4 to 8 weeks to make the cells and then get their disease better controlled. And I think some of the data will show that high-risk patients, we get the response rates. Maybe the PFS is still shorter, but it's still better now than it would have been down the road.
Yeah, okay.
Yeah. Great question. So again, do you think out of all the high-risk features, the therapies we have for high-risk patients, do you think CAR T is any different than other standard of care options or even other novel agents that are available?
Well, I think we're going to see some data in the next few moments where for patients with extramedullary disease, you may get responses with CARs or even bispecifics. Those tend to be really challenging patients in general. But can I say that they're better than what we traditionally think of? I don't know that I have enough data to make that statement.
Yeah, I think we'll have some data soon hopefully coming out at ASH, that doing CAR T earlier for high-risk patients tends to increase their overall survival. Again, doing it later versus earlier. And I do think that the whole goal is getting the cells for any patient that's going to CAR T, and our high-risk patients, hopefully that we're actually changing their outcomes long-term by getting it up front. But again, I have anecdotal data for now, and then hopefully some published data down the road. And then in terms of referral, I know, most CAR T isn't done everywhere. It's only at certain centers, and there's limitations. When do you like to see those patients come in?
Sooner is better than later.
And do you usually work with community doctors in terms of bridging and maybe what pre-apheresis therapy they should have?
And I think that's the advantage of referral earlier is the later you wait, the more likely that patient is to be a train wreck. And so you've got to do things that sometimes only we can do. Whereas if it's earlier, you may be able to manage them in the community while you're trying to get the insurance approvals and the apheresis set up.
Yeah, I agree. I think getting them to the cells is much more likely to happen. And then how do you explain, I love the way you explain it actually, CRS and neurotoxicity to your patients?
Well, I think in general, the fear is what CD19 CAR T cells do. Everybody says, oh my gosh, CD19 has terrible CRS and terrible neurotox. The way I think about it is that CAR T cells in myeloma, BCMA, are on average 1 grade lower than what you see with CD19. And when you get to bispecifics, I think it's 1 grade lower than that. And so I think that helps put some of the fear that a lot of patients carry into context.
Yeah, completely agree. And I basically tell them fevers, maybe a little bit of oxygen they might need, or fluids, but that's usually grade 1, 2, and that's all we see. And then neurotox, again, some confusion, maybe handwriting issues, but really we turn it around pretty quickly. Perfect. So take homes for just that patient workshop. The current standard of care is still CD38-based triplets. We do not have CAR T yet approved, so I wanted to make sure that was clear. But there is lots of evidence that I'll go over that shows that use of BCMA CAR T, including patients who are LEN refractory, is coming up. Hopefully soon we'll have approvals. Early relapse, especially in higher risk patients, is probably useful to get them to a novel therapy. And then neurotoxin and CRS are in general much less severe than CD19 CARs, but probably a little bit more involved than our bispecifics. All right, so these are the two approved CAR-Ts right now, ide-cel and cilta-cel. Major difference is that ide-cel has one anti-BCMA SFV, and cilta-cel has two different binding domains, but they both use 4-1BB as their signaling domain. Okay, so again, NCCN, we have two products up there, and I will say the biggest issue is that you have to have at least 4 prior lines of therapy. So for now, the earlier you can get those patients to us, we can get them ready to go when they are. So I like to see them at 3rd line, potentially right at 4th line, so we can get the approvals and ready to go. And again, we have CARTITUDE-1 for cilta-cel and KarMMa for ide-cel. And there is a long-term follow-up for CARTITUDE-1 being presented Friday afternoon as well. So then we have up front a little bit earlier line therapy in our first randomized studies for CAR-T for myeloma. So CARTITUDE-4 was cilta-cel versus standard of care DPD or VPD. And again, you see the hazard ratio of 0.26. I don't know where else I've seen this for myeloma before. And PFS not reached versus 11.8 months, which is what we expect. These patients, most of them were Len refractory, so got it in 2nd line. Some were in 3rd line, but majority of patients had not had DARA or CD38 before. They were able to use bridging therapy, like DPD or PVD, so drugs they hadn't seen, which helps bring that myeloma down before going to CAR-T, which is always a good thing, and decreases your risk of neurotoxicity that's delayed. And then again, the hazard, the forest plot showing that in different patients who have high risk. So if you have any one high risk feature, still likely to do better with cilta-cel. Then you have ultra high risk, 2 features, and better to do with cilta-cel. And then also your refractory status, much better with the cilta-cel. KarMMa-3 was also presented recently, and again, the first randomized study. These are patients who are a little bit 1 line later than the last study, and these patients were triple class exposed and at least Len or IMiD refractory. Again, 13.3 months versus 4.4 months. So that PFS for the standard of care is much, much lower than the last study because these patients are a little bit higher risk compared to earlier line. And then we have a couple of slides just on real-world data. So we talk about trial data, and it's great, but our real-world patients are a little bit different. So the U.S. Cell Therapy Myeloma Consortium has about 15 groups now putting all our data together. And the KarMMa criteria, patients who met KarMMa-1 criteria versus not, about 75% of patients would have not been eligible for KarMMa for our standard of care ide-cel patients. And again, PFS was still pretty comparable, maybe a little bit lower, and same thing with survival is actually even more similar with patients who met KarMMa-1 criteria versus not. But overall response rates was still about 85%, and median PFS was about 8 to 9 months for our standard of care patients. And then more recently at ASCO, we also presented our cilta-cel data for real world. And again, 12-month PFS is about 67%. Overall response rate was in the 89% for all the patients, and 57%, again, would have been ineligible for CARTITUDE. So it really does show that if we have access to it, patients do really, really well. And then just coming back to the trials and looking at toxicity, again, as Sagar said, we see CRS, but it's mostly grade 1, 2, very little grade 3. There is this delayed neurotoxicity. A lot of my lymphoma doctors sometimes are like, what is this, facial palsy, things like that. There are ways to mitigate it by giving better bridging, trying to get patients earlier where their myeloma is not exploding. If they have bad CRS, grade 3, 4, or ICANS, treating it really aggressively where that risk of delayed neurotoxicity with cilta-cel and even ide-cel does decrease, and patients have to have done much, much better with that. All right, so coming to the key principles for delivery of CAR-T, really that referral, getting those patients there at least 1 line earlier. So right now, getting them 4th line to the centers that have it. If it gets approved in 2nd, 3rd line, getting them even sooner to us. And our goal really is to work with you. These patients take a lot of care, and our centers can't do it all, and we really try to work with all our community doctors to make sure they're getting the appropriate pre-apheresis therapy so that they don't have bad T cells and manufacturing fails, but also for bridging, et cetera. So we try not to use dexamethasone or systemic corticosteroids right before cell infusion, and definitely alkylators right before collection of T cells. We do use it for bridging quite a bit, but not before apheresis. Bridging is really important, and I think you'll have more and more data showing that patients who respond to bridging do much, much better in terms of toxicity and efficacy compared to those patients who are blowing through bridging. And then we do have lots of infection prevention, and there's a paper that just came out from Mohan et al. that is really good for myeloma-specific T-cell therapies, but there's a few more that are going to come out soon from SITC and other groups too.
All right, well, let's switch gears a little bit and talk about some more, and I'm saying this mostly just to get get her agitated, some more practical options. Meaning some sort of off-the-shelf, easily available options for the management of patients with relapsed and refractory myeloma. So we're going to start with another patient. This is Jane, who presents with rapidly progressive myeloma, 76-year-old female, PS of 1 at presentation with standard risk myeloma, got DRVD and then a transplant, got LEN maintenance, then progressed and got ELO Pomdex, had a duration of response of about 5 months. Then got KD, best response was a PR with a DOR of about 3.5 months, and then got ESA added to the KD, and again about 2 months of additional DOR. Was subsequently referred to CAR-T, but has not yet been planned as yet. So the declining performance status really, I think, represents a real-world situation where many of us, as we watch patients get treatment after treatment, start to fall apart just a little bit. And so I think the real question is, given triple-class refractory, what would you think about in terms of mechanism of action as you think about treating these kinds of patients? Dr. Patel?
Sorry.
Oh, that's okay.
So I think, yeah, I mean, I obviously, she's had everything already. I'm a little, the KD and adding ESA later versus doing a triplet we can talk about, but anything off the shelf as a BCMA, I think that's a slam dunk. And now that we have available bispecific antibodies, if I had the ADC, I'd actually use that too, being older and a little bit more frail maybe.
Right, right. Yeah, I mean, I think the real question is, if somebody needs a response quickly, and it sounds like this patient needs a response, you're going to hope that the PS is going to improve. And so can you support them through something like a bispecific? And I think in many cases the answer is yes.
I agree. I think at the beginning I was a little worried about having to have patients that have exploding disease going in, but we've had great responses where, again, CRS is one-fold lower than CAR-T for myeloma, and really easy to treat, or even prophylax against maybe that some centers are doing.
Right. Right. So again, presuming a bispecific is used, how do you approach sort of infection prevention, step-up dosing with TEC and ELRA?
Yeah, so I think these are great questions that once we have it standard of care, we all sort of do it a little differently. But again, infection is the biggest thing I think that you're going to go over a little bit later. But with the continued treatment using bispecifics, we see patients still get neutropenia, get the hypogamma, and now their T cells are exhausted. So we're seeing strange infections. So for us, we actually check for even CMV and things like that before we start, because Texas, 95% of us have been exposed. Yeah. And we watch like hepatitis, all these things much more closely. And then we for certain patients, we actually give prophylaxis to, right? Like the really frail patients or those who have low CD4 counts, et cetera. We follow the step-up dosing per the label. But afterwards, my patients who have had a good response, or if they're frail with even a PR, I'll go to every 2 weeks dosing to help them out to make sure I don't cause bad infections. Yeah. Lots of IVIG.
Yeah, no, I think that's an important point, is the monthly IVIG, even in the context of what you may call a reasonable IgG level, BCMA bispecifics and CARs are incredibly immunosuppressive. When we looked at vaccine responses to COVID before or right around the time the first vaccines were available, basically there was almost no response among anybody getting BCMA-directed bispecific or CAR-Ts. So these are people that need some level of passive immunity, even if you think they're doing okay. Yeah. I think the other point to raise is about inpatient versus outpatient administration. Are you guys in or out?
We're still inpatient.
You're in. We're in and switching actually this week. And we have data that's about to be submitted using a single dose of prophylactic toci before dose 2 that seems to really drop off the impact of CRS and any ICANS data. So one prophylactic dose about an hour before the dose seems to make it even easier for outpatient administration. So it may mitigate the need for that 24-hour access. I'm not saying it's the answer, but certainly something to think about. And I think many sites are looking at stuff like that as well. All right, so I guess this one, you're supposed to ask me.
So what do you think the current status of belantamab?
Yeah, so belantamab mafodotin, and we're going to go through some of the data here, I think certainly is a very good drug in certain contexts. There are certain patients we've had who have done quite well, are older, frailer, don't want to go in the hospital, and I think we're going to see the data from DREAM-3 that unfortunately led to the withdrawal of the drug, but there are 3 other trials that are in development, and we're waiting for readouts in the next year, and I suspect one of the things that many of those trials have done is change the dose and change the schedule. And those of you who've given belantamab mafodotin know that you can rarely keep people on the every 3-week schedule. I had a patient that was on for 2 years, but we dosed her every 6 weeks. And it worked actually quite well for her in that context. So I think we're going to see combination regimens that use a BCMA-directed antibody drug conjugate, change the dose and frequency so that you don't have to be so dependent on an ophthalmologist or so worried about some of the ocular toxicity.
Yeah, I was just going to add, I have a couple of patients post-CAR T where they were the last ones to be able to get it. We did it with POM, off-label, but they've gotten it twice in a year and they're in complete remissions, right? So I think still a great drug to hopefully come back.
Yeah. So I think given that we always need options, it's nice to have additional tools in our tool belt, if you will. So I think we've talked about a lot of these. Again, the short hospitalization right now on label, but I think you're going to see a lot of papers and experiences coming out, switching this to outpatient management, using preemptive therapy either with corticosteroids or tocilizumab to try and reduce the severity of CRS. ICANS, at least in my experience, I can think I've only seen it once really with a patient. Most of the time it's going to be CRS, and most of the time it's grade 1 and manageable with a little bit of toci as well. The infection prevention is key, and I completely agree with Dr. Patel. The idea of dose reduction, we're actually treating TEC like we treat DARA. So every week for 8 weeks, and then every other week for 4 cycles, and then we're going to once a month. And there is certainly data from some of the Majestic trials suggesting by reducing the frequency, the infection rate drops off pretty markedly as well. And the PFS rate looks pretty similar between them. So I think these are strategies that you need to be aware of.
Agreed.
Okay, so let's talk about some of the data, the hard data in terms of updates on the approved agents here. And what you see is sort of the structure of many of these molecules, and the idea that unlike DARA or ELO or rituximab, where the 2 arms of the Y are the same, where it's CD38, SLAMF7, or CD20, here in a bispecific they're different. So one binds BCMA or one binds CD3. And that really brings the myeloma cell in close proximity to a T cell, and that ultimately activates the T cell and results in myeloma cell killing. So it is in many ways sort of the poor man's CAR T, if you will, because it may do the same thing, just isn't ex vivo engineered and not quite as targeted as a CAR T cell may be as well. Now, what we know about teclistamab, which has been available for a while now in the US, is that the overall response rate in the Majestic 1 trial was in the 60s here. You can see a significant proportion of patients achieved CR. And just like with DARA, you may see that lingering low-level paraprotein, and that's actually the TEC. It's not actually the original M spike. So mass spec may be something that helps us to differentiate that and identify true CRs from low-level antibody like we see in the context of daratumumab. But I think the really high VGPR or CR rate in the context of penta-refractory patients is really what distinguishes this class of agents. And what you're seeing here are progression-free and overall survival curves, not just for all patients, but patients who do achieve a stringent CR. And again, these are 5 to 7 prior lines of therapy. Seeing PFS curves that are well beyond a year certainly is really exciting, and it's rare in the context of heavily pretreated patients, which gives us good hope for moving it earlier and earlier. Now, we do know that some of the things that are always bad may still be bad in the context of these new therapies, but they may be less bad. And what I mean by that is, yes, these are some challenges, particularly extramedullary disease and high tumor burden, but these are patients that do respond. And then the question is, what can you do to maintain that response? What can you do to consolidate that response? We know extramedullary disease is a significant challenge for all of us. When you look at safety issues outside of CRS and ICANS, which are listed here, we do see some cytopenias. And I think that the neutropenia and the thrombocytopenia, from a mechanistic perspective, is likely a consequence of inflammation in the marrow when you're killing myeloma cells. So that low-level CRS is still enough to cause some local inflammatory effect that causes cytopenia. So even though it is targeted to BCMA, you can get neutropenia and thrombocytopenia and anemia, and I think that's just part of the mechanism of action, if you will. You'll notice here infections are certainly very significant, and this is why I think we've all harped pretty significantly on the idea of prevention and prophylaxis. There is a paper that several of us are on that just came out in Leukemia, I think, that are some guidelines on how to do infection prevention and prophylaxis in many patients getting BCMA bispecifics. I'd recommend you look at that just to get a sense for what to do. Now, elranatamab is the newest kid on the block. It's another BCMA-directed bispecific. It is structurally different from teclistamab. Whether it's functionally different from teclistamab, we don't know the answer right now. And I think that's something that all of us are looking forward to hopefully being able to tease out. But again, you can see this was over 100 patients. Again, the VGPR or better rate very, very high with elranatamab. And when you begin to look at progression-free survival curves, not just for patients in general, but with stringent CR, and this was published just a couple weeks ago in Nature Medicine, what you're seeing again is sort of these unprecedented durations of response, particularly amongst the majority of patients who achieved a stringent CR or a VGPR or better. So certainly very active as well. Now here's the step-up dosing, and I don't know that there's a lot to understand here except you really should do it. If you don't do it, your CRS and ICANS rates are going to be much higher. I think if you look at differences between the two drugs, you get to a bigger dose faster with elranatamab than you do with teclistamab. Whether that means anything down the road, I think is hard to know, but maybe a consideration if you're thinking about a patient who needs a quicker response. Getting to that full dose within 3 days as opposed to waiting a full week may be something to think about. We don't know whether that really matters. What about belantamab? We talked about this a little bit. Belantamab mafodotin is the antibody drug conjugate that you see here. Again, it works through 3 mechanisms. It does bring chemotherapy into the cell. It also does induce ADCC and ADCP through effector cell function and actually results in immunogenic cell death. And this was the DREAM2 study that led to the FDA approval of belantamab mafodotin with a median DOR of close to 13 months. And with longer-term follow-up, we're not seeing new adverse events. And in fact, the immunosuppressive infectious complications are actually less with this BCMA-directed approach than they are with others that are a little bit more comprehensive. So certainly from a tolerability and a frailty perspective, this is you come in once every 3 or more weeks. It's relatively easy to give for a patient. And so for the patient that lives far away that doesn't want to come in quite as often, this may be a really important endpoint. Now, the trial that ultimately was not positive that led to the withdrawal of belamaf was the DREAM3 trial. And what you can see is that the PFS was 11 months versus 7 months here, so it was different. The response rate was higher. It was just not statistically significantly higher for both arms. And while it's clearly trending in the era of improvement, the FDA felt this wasn't significantly positive to allow the drug to stay on after accelerated approval. As I said, this was using the traditional dose and schedule for belamaf. I think you're going to see modifications that make it a little bit easier to stay on longer, and the combinations I think are going to end up being really bringing this drug back. So again, here's some of the summary of what we've already said. Ocular adverse events really are supportive in management. If you've got patients that are still on, you have to do it through a special protocol. I think our last patient just came off of that special protocol. Looks like you've got somebody.
I still have somebody.
You still got somebody. All right. So they are available, and there are ways to get it for patients going forward.
Okay, so now we're going to go a little bit on the next phase of BCMA, sort of the earlier and then the non-BCMA antibody platforms that are really exciting. So coming back to the patient Dr. Loniel just talked about, do you have clinical trials for relapse refractory patients?
Yeah.
Okay, so if you and I are always going to say, of course, for clinical trials, this is our plug to say, bring your patients over. We have lots of great new things coming. Again, new targets, new other things, mechanism of action that we would love for patients like this to go on to. Again, has had CD38 twice now too, right? And then what other BCMA bispecific options could be considered Would you give them any? Would you give bispecific after bispecific? Any thoughts on that?
Yeah, I don't have an issue sequencing bispecifics,
Okay.
so that would be one potential way to look at it. Yeah.
And I think learning different, now that we have a different target, right? Would you do something different? So now this patient got a BCMA antibody, duration of response was 12 months, which is much better than the last 3 regimens this patient had. So again, why we would give it instead of waiting. And so now they've had BCMA therapy. Do you recommend a different mechanism of action, or would you think maybe talquetamab as GPRC5D, but still being a T-cell engager could still work?
Yeah, I mean, I think what we're beginning to learn is that if you're progressing on a BCMA bispecific, the mechanisms of resistance may not be mostly immune in nature. They may be receptor mutations or other changes, and so I would think about switching the target, but potentially staying with the bispecific.
Yeah, no, I agree. And I think there's some retrospective data from Mount Sinai that shows going one to the other actually works really well. So yeah, for me, changing the antigen probably means much more than, especially for bispecific to bispecific. Perfect. Oh, and then one other thing I was going to ask that I forgot, AEs. So for talquetamab, the AEs are very different. Thankfully, infections are a lot less. There's still some, infections you have to look out for, but not like the BCMA therapies. Any other AEs that you think are, worth discussing with your patients before you start?
Yeah, I mean, I usually do raise the skin, nail, and the GI stuff because I think those are real, and they're harder to manage without dose reductions and dose modifications. So it's really about giving them a break away from therapy, but those are the issues I bring up.
Perfect. Awesome. Okay, so in terms of the patient take-home, so multiple BCMA agents are in development. So it's not just TAC-NAP, but we have Linvo, elnuctamab, of course, Elra just got approved less than a month ago. Clinical trials are always an option. And then, we do really discuss lots of different aspects of BCMA bispecifics. It's not really just like any of our other, off-the-shelf medications out there. They need specific infection prevention and follow-up. And then recommendations for our patient if now they've had BCMA exposure. We do like to switch targets after BCMA, potentially, especially if it's the same mechanism of action. I don't think we have any data to say that even though we have all these BCMA bispecifics coming out, if you're relapsing on one, we can just do a different one instead, right? No real data for that. Talquetamab is approved for a different mechanism of action and a different antigen, GPRC5D. And then I think current data does show that BCMA antibodies can be active after other BCMA therapies, and I would say especially CAR-T. So going over the other novel BCMA and other mechanism of action bispecifics or other targets. So we have linvoseltamab that was presented just at EHA and ASCO. So this is a little different in that the administration's IV. Then we have the ABBV-383, which is an IgG4 bispecific. Again, IV every 3 weeks. Elnuctamab, which is an IgG1 bispecific antibody for BCMA. And then you can see it's sub-Q, but again, step-up dosing day 1, 4, 8, and then 15, 22 of cycle 1. Goes to every 2 weeks, and then it goes to every 4 weeks starting cycle 7. And then the newest one, cevostamab, that's still in studies, but it's a different target we haven't talked about yet, FcRH5, also very ubiquitously expressed on malignant plasma cells. And this is the full dose IV over a 21-day cycle. There is a step-up dosing for cycle 1. And then there's, the one important thing about this is that after 17 cycles, you can actually stop treatment. So it's the only fixed duration, which I will say is very important for our patients in terms of quality of life. So something else we're looking at with other BCMA bispecifics as well. So just a little bit about Linvo, BCMA CD3 bispecific antibody, again, targets T-cell effector function to cause cytotoxicity, just like our other bispecifics. But linker is their study that was presented, and again, the recommended dose was 200 milligrams. Patients were median 6 prior lines of therapy, 90% triple class refractory, and at 6-month follow-up, the response rate for that 200 milligram dose was 71%, and 59% greater than a VGPR. And of the 30% that got stringent CR, of the evaluable patients, more than half were MRD negative at 10 to the minus fifth. And then looking at the 2-dose levels, so again, the 200 was picked because median PFS is not reached yet, versus the 50 milligrams was about 7.9 months, which again is still pretty impressive for 6 lines of prior therapy. And again, most of the CRS is a little different with this one. Happens at the priming dose, the 5 milligrams. Then you see it drop at the 25, and at the first full dose, less and less over time. So again, each week it's actually a less likelihood of getting CRS. And there was no grade 4 or 5. There's actually no grade 3 or higher CRS either, which is, again, a lot of our bispecifics. So again, this is a step-up dosing. It's a little different week 1 and 2 versus weeks 3 to 6. And then, so it's cycle 1, weeks 3 to 6, 200 Q week, and then it continues on. And if depending on your response, so after cycle 6, if you've had a VGPR or better, they're dropping it to Q4 weeks versus less than VGPR, you continue at the 2 weeks. So kind of using a response adapted evaluation. So again, coming to talquetamab now, just got approved and is on NCCN as at least 4 prior lines of therapy. Does not necessarily require prior BCMA, so we'll talk about that too. But a new target, GPRC5D, again, very ubiquitously expressed on myeloma cells. And for talquetamab, this was the Monumental 1 study, 2 doses were tested, and again, median 6 previous lines of therapy. So greater than 71% overall response for all doses, but 0.4 and 0.8 were similar in overall response rate. Maybe a little bit more deeper response in terms of CR or stringent CR, but otherwise VGPR greater is similar. And those who were prior refractory cohort was 65%. So still patients had great responses despite being triple class refractory. And so coming to the AE, so Sagar and Dr. Lonia talked about this a little bit. They're different. The GPRC5D is on some endothelial, it's expressed on endothelial cells, and so there are taste changes with dyschezia, skin-related, nail-related changes. The taste changes can cause weight loss and rash. So really, monitoring these symptoms early with your patients to say, okay, let's hold it to see if you can improve it, and patients do well. So nothing that's necessarily fatal, and like infections, again, half the risk rate of grade 3, 4 infections at 19.6%, but just different side effects we need to monitor in terms of quality of life. And then the last slide, really now, again, as myeloma doctors do, we like to combine everything. And I think in the end, how are we going to get the functional cure for our patients, or more of our patients? It's going to be how do we use different mechanism of action or novel therapies against different antigens. So now you have BCMA and GPRC5D in the redirect study. And this was presented at ASCO and HIA. And again, it was a phase 1b trial of TEC and TALC together. Again, showed safety profiles similar to the both trials, but amazing response rates, 96% at the phase 2 dosing, 86% for patients with extramedullary disease. So pretty phenomenal for some of our really relapsed refractory, or even our high-risk patients, I should say. We are with audience Q&A.
All right, we've got 5 minutes for Q&A here, I think. And let's see what we have here. So, all right, sequencing of CAR T versus bispecific. I think we've talked about that one.
Yeah.
Okay. Is 1Q considered high risk if no other high-risk cytogenetics?
Yes, I think,
yes.
yeah, for sure. And it depends on the amplification, 1Q, and like the number, copies, et cetera. But I think more and more data has shown that, yes, these patients are high risk even on their own. Definitely if they have other 17P, et cetera, ultra high risk is really bad, but we still consider them high risk.
And there will be a new definition of high risk coming from the IMS probably in the next 6 months or so. And 3 copies of 1Q is not going to be considered high risk in their category, but they're recognized that there may be an between standard and what they're defining as high risk, and it may fall in there. Neurotoxicity, Parkinsonism with BCMA CAR T treatment and prognosis.
Yeah, great question. So we've seen in the real world data that a lot of patients do get facial palsies, which aren't necessarily Parkinsonianism. So there we do high dose steroids, sometimes IVIG, and for most patients it resolves or at least decreases. If someone has true Parkinsonianism, it is much harder to treat. We do IVIG, plasmapheresis, high dose steroids, et cetera. There have been drugs like anti-Parkinsonian drugs that have been tried, and it doesn't work. So what really the management strategy is, prevent it. And that we know we can do by going in with less myeloma, better bridging. And if someone has high-grade CRS or ICANS, really treating it with high-dose steroids, bringing it down, and that way it prevents this from happening.
Okay, so what pre-med is advised to prevent facial palsy?
Yeah,
I want to know the answer to this too.
If we knew who was going to get it, it would be great. But I just recently had a patient who was in VGPR, had grade 1 CRS, was outpatient for Cilta-cel the whole time, and then got facial palsy. So it's hard to say who should get prevention. But again, steroids worked for him to bring it down after. So I don't think you can prophylax.
All right. Is it still effective to give BCMA CAR T after progression relapsed after BCMA bispecific? Maybe you can do the quick summary of the Bayless paper.
So I think we have a couple of papers. So, cohort 2C for Cilta-cel, Cartitude, showed that the response rate for patients who had prior bispecific or prior BCMA to CAR was about 60%. So remember, from 98% to 60%. And the PFS was around 6 to 8 months. So from 33 months to much lower. Still great, might be the best option, but much, much lower if you go bispecific the other way. And our ida-cel paper that just came out kind of shows the same thing. The prior bispecifics, PFS is much lower. I think if you do ELRA, for instance, post-CAR, your response is down by 10%. Your PFS is maybe a couple months, but still much better than the other way around.
Yeah. Here's a question about gamma secretase inhibitors. I'll start, and you can weigh in on this. So I think it's a really interesting mechanism. I don't know that it makes an existing BCMA-directed therapy better at the outset. The Hutch actually did GSI before giving a CAR T. Their response rates were pretty good. I don't know what their PFS is. That paper's in submission, I think. But I think about using it after you've given a CAR or a bispecific for a month or so, and we know that those remaining myeloma cells may be BCMA low, and you may be able to drive expression up and then maintain efficacy or improve efficacy using it later. So I think the jury's out on when to use a GSI, but I think clearly it does upregulate the expression. Whether it makes a difference in outcomes, I think is hard to know. Combo of TEC and TALC achieves a CR rate of about 40%, which is close to single agent TEC. When would you consider using this combo as opposed to single agents?
Well, the combo is actually much higher. It's
for the CR rate?
Oh, the CR rate. Sorry, yeah. So again, I think the question of long-term PFS, right? I agree. For most patients, I think the deeper the response, the longer response you're going to have. But with immune therapy, I think it could be different, again, earlier line. So I need to see that PFS. But 100% correct. If the PFS is similar, I don't know I would give patients extra toxicity without any benefit.
And to me, I think the perfect partners for the bispecifics, quite honestly, are the IMiDs.
Right.
Because we know that T-cell function and T-cell health is an important part of the efficacy of these drugs. And many ways, even the new IMiDs like iberdomide and mezigdomide are far more potent at turning sleeping T-cells to awake T-cells. And that is the technical term for those. And so in that context, may be really helpful as a partner. So I think that's it. Thank you again to my colleague and partner here, Dr. Patel, and thank you for joining us this afternoon.
This activity is provided by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Remember to download the slides and practice aids. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MKV860. This activity is supported by independent medical educational grants from GlaxoSmithKline, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Regeneron Pharmaceuticals Incorporated.